Welcome, everybody. My name is Dr. Donna Reece, and I am joined now with Dr. Darrell White, who has reviewed abstract number 141. This is a randomized trial from Italy named the FORTE trial.
Thanks, Donna. I think this is an interesting trial for Canadians looking after myeloma patients, in particular transplant-eligible myeloma patients. And this study included 474 newly diagnosed transplant-eligible patients under the age of 65. There were 3 arms: carfilzomib, lenalidomide, and dex for induction, then transplant, and then KRD consolidation, versus carfilzomib, cyclophosphamide, dex for 4 cycles induction, then transplant, and then KCD consolidation, versus carfilzomib, lenalidomide, and dex alone without transplant for 12 cycles. There was a second randomization to maintenance with either carfilzomib, lenalidomide, or lenalidomide alone. The primary objectives were efficacy and safety.
There was a lot of information in this abstract and presentation. What caught your attention the most?
So I think the main takeaway is that KRD with transplant is superior to the other 2 arms in terms of progression-free survival. And interestingly, that includes the KCD arm with transplant. KRD with transplant was superior to the KRD for 12 cycles, suggesting that transplant still has a role with the so-called novel agents. The KRD arm with transplant showed about a 78% 3-year progression-free survival versus 58% for the KCD arm with transplant. That's about a 47% benefit, and that's statistically significant and I think clinically relevant as well. The second major point in this study is the second randomization to maintenance, which compared carfilzomib and lenalidomide to lenalidomide alone. And in this case, KR is superior to R alone as a maintenance regimen, and that's new information, and that's a more aggressive regimen for maintenance than we would typically use. There's a high rate of MRD negativity in this trial, and we've seen some of this previously. They're hitting high rates, particularly with the KRD and transplant arm, and now they're presenting sustained MRD negativity rates at 1 year. So with KRD and transplant, there's a 68% sustained MRD negativity versus 54 and 45% for prolonged KRD and KCD with transplant, respectively. Additionally, they're showing conversion from MRD positive to negative in the maintenance setting. So with KR maintenance versus R maintenance, the conversion rate's about 46% versus 32%, suggesting that the addition of carfilzomib to our regular maintenance protocol would lead to deeper response for the patients. And then finally, in terms of safety, there's the usual expected hematologic toxicity. And additionally, there is some non-hematologic toxicity, particularly adding carfilzomib to lenalidomide for maintenance. The toxicity itself is expected. It's in the, for example, 3 to 4% range for cardiac toxicity, and includes some hypertension as well. So overall, the KR maintenance is not without toxicity, and some of that is non-hematologic.
Given these results and the suggestion that we can do better than CyBorD, what do you think the relevance is for the clinician practicing in Canada?
So I think this is, for now, something for us to keep our eye on. This regimen wouldn't be available in Canada or wouldn't be funded in Canada as is. However, it does suggest that induction and consolidation are important, and that the choice of induction regimen is important as well. So it's possible that we need to think about a different induction regimen versus our sort of tried and true CyBorD. Typically, we aren't using consolidation post-transplant, but might consider that as, again, in this trial, results seem superior. So I think for now, it's something we should keep our eye on, probably not practice changing at the moment.
Thank you. I think there's a lot of food for thought here and guidance for future studies and initiatives. Thank you very much.
Thanks, Donna.